let's read what horseshoe kidney is. They're saying inferior poles of both kidneys are gonna fuse abnormally, just like in this picture, where this pole is fused with this pole. So instead of being two separate kidneys, you have a one whole kidney. As they ascend from the pelvis during fetal development, horseshoe kidneys get trapped under the inferior mesenteric artery and remain low in the abdomen. So they're saying here is that generally the kidneys are supposed to ascend or go up from the pelvis, right, when they are still in development. But what happens with horseshoe kidney is that instead of going up, on their way going up, they're being trapped by the inferior mesenteric artery. So if you take a closer look, this is my two kidneys. Generally, they're supposed to ascend up from the pelvis into their normal position, but with the horseshoe kidney, they're being trapped by the inferior mesenteric artery, and this is high yield to know that's the IME that they're being trapped by, right? So as they ascend from pelvis during fetal development, horseshoe get trapped under the inferior mesenteric artery and can remain low in the abdomen. Now, kidneys can function normally, but they're associated with things like hydronephrosis. This is high yield, which is the buildup of urine, okay? Hydronephrosis, if you think about it, the kidney normally produces urine, right? Now, since I'm having the kidneys that is conjoined, this is where urine is going to build up in the kidney, leading to hydronephrosis, aka uretero-pelvic junction obstruction. Other things that can happen is renal stones, infection, and a higher risk of renal cancer, which makes sense. Okay, so this is something to keep in mind. High risk of renal cancer, say like Wilms tumor in children. Last point is the higher incidence in chromosomal aneuploidies. Like what? Like Turner syndrome, and that's a common one with horseshoe kidney. Like trisomy 13 or 18 or even 21. So just keep that picture in mind. This is a CT scan that is showing you the kidneys that are being conjoined. That's a horseshoe kidney. Underneath the kidney here is the inferior vena cava, and then here is the aorta. Just keep this in mind, and you always need to contrast this picture with the normal kidney. So here's a picture of a normal kidney. You're supposed to have a kidney here, a kidney here, right? What we're having in horseshoe kidney, both of these kidneys are joined abnormally to make only one kidney. So this is horseshoe kidney. For them, it looks like a horseshoe. To me, it looks like a U shape. So it's up to you what you consider that to be. Alright, so let's go ahead and do a USMLE-Style question. This is going to be question number 1. So here they're asking which of the following findings is most likely to be associated with this patient's condition. What do we got here? A 4-year-old male presents with a palpable abdominal mass and a history of recurrent UTI infections. On imaging, there's an abnormal kidney configuration with a dilated renal pelvis and hydronephrosis. The kidney is located lower than usual in the pelvic region. This is important. The patient is otherwise healthy and has no significant past medical history, and they're asking what is associated with the patient's condition. Is it elevated serum creatinine, or coarctation of the aorta, or Wilms tumor, or malrotation of the gut? The answer is going to be Wilms tumor. So why is it Wilms tumor? Remember, we said that horseshoe is associated with tumors, right? It's associated with renal cancer. There's a high risk of renal cancer. So in that case, considering this is a young boy, the most common renal cancer associated with a young age group is Wilms tumor. Let's go to question number 2. So here they are asking us which of the following embryologic events most likely explains the patient's renal finding. So this is an embryology tie-in. That's my least favorite. Here we have a 5-year-old boy is undergoing evaluation for persistent hypertension. He's a very young patient. Persistent hypertension and recurrent UTI. His past medical history is significant for mild developmental delay. Physical exam reveals a palpable midline abdominal mass. And the lab results are as follows. Serum creatinine is 1.3, so that's elevated, so there's a problem with his kidneys. Urine analysis, there's microscopic hematuria and mild proteinuria. Again, his kidneys are at fault here. And blood pressure is high, again indicating that there is an issue with his kidney. Now, they say they did a renal ultrasound, demonstrated bilaterally fused renal tissue located inferiorly in the abdomen. So this is the key point here. With signs of hydronephrosis, further workup reveals 45X karyotype. So what that means is that further proves my point is that, okay, he's having bilateral fused kidneys along with a hydronephrosis, along with the 45X karyotype, which means this is Turner syndrome. So this means that this is typical horseshoe kidney disease. Now they're asking, considering we know that this is horseshoe kidney disease, now they're asking which of the following rheologic events most likely explains the patient's renal findings. A, failure of the urethric bud development, or is it B, abnormal interaction between the metanephric mesenchyme and the urethric bud? Or is it C, which is vascular entrapment during ascent of the kidney? Maybe. Or D, defective separation of the cloaca? Or E, lateral displacement of the nephrogenic cord? The answer is going to be C, which is vascular entrapment during the ascent of the kidney. Why is that? Why is that? Well, this patient, like I said, has horseshoe kidney disease, right? And the horseshoe resulted in the fusion of the lower poles of the kidney when he was in early fetal development. And as his kidneys ascend from the pelvis to the abdomen, they became trapped by the inferior mesenteric artery, so they did not reach the normal position. And the Turner syndrome, which is the 45X karyotype, is, like I said, further supporting our diagnosis. The patient's hypertension, hematuria, and everything else, compromised renal function, also can occur due to abnormal renal architecture. Now, let's see, why are other options incorrect? So why is A incorrect, which is the failure of the urethric bud development? So the urethric bud is the one that generally forms the kidneys. So it forms the ureter, the pelvis, the calyces, the collecting duct. So that's most of the kidney. So if you think about it, if you're not having a urethric bud, which is what's going to form most of the kidneys, then in case of A, if I'm saying I have failure of the urethric bud development, then either I'm going to have renal agenesis or Potter sequence. So why is it not B? Abnormal interaction between the metanephric mesenchyme and the urethric bud. And this is going to lead to multicystic dysplastic kidney or renal hypoplasia. And then why is it not D? Then this is going to be associated with urorectal anomalies, okay? Like a persistent cloaca, but this will not be associated with renal fusion. Why is it not E, which is the lateral displacement of the nephrogenic cord? This could lead to ectopic kidneys. Now let's go to question number 3. They're saying which of the following is most commonly associated with this condition. 25-year-old woman presents for a routine physical exam. Okay, she's a 25-year-old woman. She reports no significant medical issues, but mentions that she has a history of recurrent urinary tract infections, and occasional flank pain. On physical exam, she is found to have a palpable mass in the lower abdomen. A CT scan reveals an abnormal kidney shape with both kidneys fused at the inferior poles, and they are located lower in the abdomen than usual. The kidneys are positioned under the inferior mesenteric artery. The patient is diagnosed with horseshoe kidney disease. So now we know that we have a 25-year-old woman that is diagnosed with horseshoe kidney disease, and they're asking which is most commonly associated with the condition. A is hydronephrosis due to uretero-pelvic junction obstruction, yes. Polycystic kidney disease, no. Renal artery stenosis, no. Nephrotic syndrome, no. Renal vein thrombosis, no. So the answer is going to be A, hydronephrosis due to uretero-pelvic junction obstruction. Let's go to question number 4, our final question here. So here they are asking you, which of the following is the most likely pathophysiologic mechanism for the development of hydronephrosis in this patient? Here we have a 28-year-old male presents with intermittent lower abdominal pain, recurrent urinary tract infections, and occasional hematuria. His past medical history is significant for horseshoe kidney, which was diagnosed incidentally on imaging during prior follow-up for flank pain. On physical exam, there is mild suprapubic tenderness. A recent CT scan confirms the presence of horseshoe kidney with moderate hydronephrosis on the left side. Urodynamics reveals normal bladder function. A recent genetic panel for common renal conditions is unremarkable. Now they're asking, what is the most likely pathophysiologic mechanism for the patient developing hydronephrosis? Is it A, increased intra-abdominal pressure due to abnormal kidney positioning, or B, compression of the renal pelvis due to abnormal fusion of the kidneys, or is it C, obstruction of the renal papilla caused by congenital malformation of the renal tubules, D, reflux of the urine from the bladder into the kidneys due to VUR or visoureteral reflux, or E, decreased renal blood flow leading to chronic kidney damage and obstruction? Well, the correct answer is going to be B, compression of the renal pelvis due to abnormal fusion of the kidneys. Why is that? Well, because B is the answer that's kind of focusing on the key aspect of horseshoe kidney disease and everything that we discussed so far, which is the compression of the renal pelvis. And why did the compression of the renal pelvis happen? Because of the abnormal fusion of the kidneys. This is keyword. Abnormal fusion of the kidneys is kind of a buzzword for horseshoe kidney disease. And this abnormal fusion of the kidneys is what ended up compressing the kidneys. So we had abnormal fusion of the kidneys, and this abnormal fusion of the kidneys is what ended up compressing the renal pelvis, is this one right here. So because you're having abnormal fusion of the kidneys, the renal pelvis is going to be compressed. So this area right here.